Welcome to today's Substance Use Echo. I'm Leo, the project assistant for Project Echo here at the Institute. If you could please drop your name and contact information in the chat, it would be really appreciated. It just helps us network with each other and helps us contact one another if we have an idea or a resource we maybe would like to share with each other. And if closed captions do make the session easier to follow, you may go to the More button on the toolbar and you can toggle those on. We are recording today's echo session for educational and quality improvement purposes. So when joining and participating in the session, you are consenting to being recorded. And if you don't wish to be recorded, please disconnect from the call now, but we really would like to have you. And Echo is an interactive community, so we have our presenters, our stakeholders, and community members engaging with one another. Whether it be really sharing resources or giving recommendations on a case, participants are expected to be engaged in asking questions, maybe after the didactic presentation. But if you do have a question that it's really pressing, you can drop it in the chat and we can get that answered for you as well. Case narratives and discussions are also just a really great way to get support on a really difficult case and apply those strategies from our echo sessions to those real world problems. So if you haven't presented a case narrative yet, I really urge you to do so. And if you want to, you can email projectscope@usu.edu and we can get that set up. And let's also remember to please protect individual privacy. So we do work with some sensitive topics, so please take a moment to de-identify those situations if you are sharing them. And if you are unsure about a statement or question, you can always reach out to one of our hub members who should all have those asterisks by their name. The hub member monitoring today's chat is Janelle Preston, so they can address those concerns, comments, or questions that you may have. And there's three key components to an echo session. The first is our didactic speaker, who's going to be Sydney O'Shea for today, and she's presenting on stigma surrounding families. And our second key component is our case presentation, which will be in the format of community questions. And our last component is professional networking, which can really happen in our breakout rooms or by reaching out to someone in chat, etc. Echo sessions are just a great way to network with others from maybe your profession or from similar organizations and get some really great ideas. And also, please remember to rename your profile to your first and last name, your state, your job title, and your organization. And if you don't know how to do that, you can click on that Participants tab at the bottom toolbar, and you can hover over your name and select Rename when clicking those little three dots next to Unmute. This is also how to raise your hand. It's just a helpful feature if you maybe have a question for this facilitator and you don't want to interrupt the person speaking. So it's just a nice function to use, and it's in the Reactions tab at that toolbar at the bottom of your screen. And now to just go over some really quick etiquette in our echo sessions, just remember to please respect the presenter by using chat or raising hands to contribute when the presenter is speaking. Let's also keep our questions brief and on topic as it really helps everyone get into the conversation. It also assures we give our full attention to the presenter. And if you could, please just introduce yourself and your organization before asking a question. And last, we do really encourage you to turn on your camera as it really just helps us connect over this virtual echo session. And this is just how to get credit for attendance. Tori will be dropping that survey link to get that credit of attendance, and it's presented in the form of a certificate of attendance. And we really do value your feedback. So I really urge you to take that survey that Tori is going to be dropping in the chat. We always use those survey results to improve the quality of these echo sessions, and it really lets us know how we can help you better. We also have a place in our survey that asks for an email, phone number, and mailing address. That's just so we can send you free swag if you've attended enough sessions. And Canvas is also the platform we use to put resources from today's session and past sessions for you to access. So if you would like an invite to our Canvas page, you can email projectscope@usu.edu. And here's just another plug for those case studies. I just think it's a really great opportunity to receive some valuable and applicable feedback or maybe hear an idea that you haven't thought of previously. And if you do want to set up a case study, you can always email projectscope@usu.edu and we can always get that set up. And also, please remember to follow us on our social media pages. This is where we post some updates and reminders. We also post information from session or some impactful quotes. And these pages are just a good way to stay connected with one another. And our Facebook group is also just a good way to stay connected with one another. So you can join that as well. But now that I have the housekeeping slides over with, I can turn the time over to Sydney.
Awesome. Thank you so much. Okay. I'm going to do the shuffle to share my screen before I get started. Just one moment. Okay. Okay. Awesome. It's our full screen. Okay. I'm assuming everyone can see it. If not, somebody just pipe in. But my name's Sydney O'Shea. I'm really excited to be here today. I am thankful to have an opportunity to talk to you all about my research. I am an assistant professor at Utah State University in communication studies. I'm a health communication scholar, so I have been trained in health communication. I do also have a public health background. So my work and my training has been very interdisciplinary in nature, which I feel is really kind of one of the best ways to tackle big problems like stigma, right? We need to have a variety of expertise in the room to try to address these issues. So I also have a lab. It's the Research on Equity, Advocacy, and Communication in Health. So the REACH lab, and that is a part of my department here, Department of Communication and Media at Utah State University. So I'm going to start by telling you a little bit more about why I do this work before we dive into the research I've been doing. So I have been investigating how families experience and manage having a loved one with a substance use disorder for over 10 years now. My work is mostly qualitative, so I do a lot of interviews with families and in a wide range of different types of families. So that's something that is very important to me, primarily because my family has been deeply impacted by substance use. So I've got a couple of images here. You'll see in this first one where there's a Santa Claus. That's my brother Zach, but the one next to him is my brother Jake. And uh, in 2014, my brother passed away due to an overdose. And then my sister over here is holding my very newborn baby, Thomas, who will be 11 in like a week, which is bananas. But she also has passed away due to an overdose. So these are things that are incredibly important to me. And I don't share this to be super personal, but also for you to know that these are real things that impact people's lives that you may never even, recognize that it's something that they've dealt with. And I probably don't need to tell that to all of you here because you're here for a reason that you want to learn about this. But it's just important to understand that and then also know that these experiences have shaped how I approach my research as well. My perspective has largely been guided by this not only assumption, but evidence that shows that most of the resources that we have for folks who are impacted by substance use go towards the individual with a substance use disorder, which of course is warranted, necessary, needed. However, oftentimes families are then left behind and they don't really receive the resources that they need. And so my work has really tried to fill that gap and focus on the families. My argument is also that if we can help the families cope, they'll be better positioned to help their loved one as well. Right. So that's kind of the position that I take. Today, as we move forward, I'm going to talk to you about the research I've been doing over the past 10 years. We'll start by giving you just a little bit of a background about family substance use and stigma, just for those who aren't super familiar, but just a couple details. And then we'll dive into what my research has said about the ways that families experience stigma related to substance use, how they navigate that stigma, and then we'll talk about some key takeaways from my research over the years and what I'm working on now and what's next. I am pretty casual, so if you have questions, you're welcome to, of course, raise your hand or put the questions in the chat, and I'm happy to answer those at any time. I just love any opportunity to kind of nerd out about my research, so I'm, again, just excited to be here. Okay, so let's start by talking about substance use in families. We know that in the States, over just under half of adults in the United States have a family member or a confidant, so a very close friend, with a current or past drug addiction. So this is obviously a widespread issue. We often refer to folks who have a loved one with a loved one with a substance use dependency as an affected family member. So you might hear me say that throughout the presentation today. But there is excellent research that shows that this group of people, affected family members, are underserved when it comes to addressing the opioid crisis and other substance use issues like alcoholism and things like that. And there's a growing body of research that is recognizing this. I should also mention that I'm a member of a work group with the Consortium on Addiction Recovery Services Research, which is affiliated with the National Institute on Drug Abuse. And it's a group of scholars from across the country who have gotten together and focused on this Engaging Loved Ones initiative, which is trying to guide funding initiatives for research like mine, where we're focusing on the families. So in addition to the research showing this, also like NIDA is trying to put some more resources as well to families. So thankfully support is growing, but we still need people to pick up this work and move it forward. Families experience a lot of consequences when it comes to substance use. Stigma, obviously, I'm going to focus on that today, but we have stigma that comes from the public and others, but also self-stigma. Sometimes it's not even anything someone else says. It's just the way we feel about ourselves. And that also has a negative impact on individuals. Substance use in the family can also impact psychological well-being. It can lead to social isolation. It can cause family dysfunction and really just lead to an overall poor quality of life. So really, we're seeing some vast consequences when families are dealing with substance use. If we talk more specifically about stigma, I'll define it and then we'll talk a bit more about the actual consequences of just stigma. So for those of you who aren't familiar with an actual definition of stigma, we hear stigma a lot, but sometimes it's one of those words that we just kind of hear and based on context know what it means, but we don't actually really sit down and think about it. But essentially, stigma is when a group of people are kind of marked and labeled as being others. So there's them and there's us. And that is because of some kind of attribute that they carry that is discredited. So of course, we're talking about substance use stigma today, but this can be related to so many different things such as body weight, disability, poverty, right? And we can go on and on about all the different ways that folks can be stigmatized. But essentially, folks are labeled and set apart, and that process leads to various consequences. Another type of stigma is called courtesy stigma, which I think is a bit of an ironic name, but essentially it's when a family member or somebody else who is associated with an individual who bears a stigmatizing trait has the courtesy of also being stigmatized because of that affiliation, right? And so families then, in the context of substance use, experience family stigma because of the loved one's substance use. We've also seen this a lot, like if you think back to like 80s and 90s with HIV, anyone who considered themselves an ally with like LGBTQ population was also considered stigmatized because of that affiliation, right? So just another example to help understand that. But here, in the context of family substance use stigma, one individual's behavior or actions then kind of leads to the whole family being judged and set apart from society, right? In addition to the consequences we already talked about of just general substance use, there are additional consequences for the stigma, right? So these consequences are in addition to what I've already covered, okay? But we can think about these as compounded consequences then. So additional negative mental and physical health outcomes. There are issues related to employment, housing, and medical care, and that can be discrimination, but it also can be because somebody is caring for their loved one with a substance use disorder, and so they're facing issues at work, right? Can be something like that. There is discrimination and isolation, and we also know that when you match individuals on all other characteristics, family or people who experience stigma also experience more illness symptoms than others. So it's manifests in the body too, right? It's not just a psychological well-being issue that transforms into
y sal
other.
pendiente de eso y ellos te van a ayudar.
And then also the psychological distress
If
again.
I can just remind you guys all to mute.
Thanks, Janelle. I appreciate it.
Uh-huh.
Okay, so at this point, I think we've gotten the point, like stigma, not great, right? But it is a reality of the lived experiences of people like myself who've been impacted by substance use in the family, right? So what I want to talk to you moving forward about is how my work then aims to address the stigma that families experience. So as I've been interviewing folks over the past 10 or so years, I have talked at length with them about their overarching experiences of their family as they've navigated their loved one's substance use disorder. But I've also kind of dived deep into that stigma experience. And I'm also working on some things to catapult that work forward too, that I'll touch base on at the very end today. But this really has been the main area of my work since I was a master's student, really. So it's been something that has carried through with me for a very long time. Okay, so what I'm going to present to you today are just a lot of, I shouldn't say a lot of, but quite a few exemplars from my studies, and then I'm going to give you some context about them. But I thought it would be really effective to show you what my participants have said about their experiences. I think it helps really place us in their shoes, right? So let's start by talking a little bit about the ways that families experience stigma and how they talk about it. So this first exemplar that I have to show you is from a 27-year-old male. He is a brother of somebody with a substance use dependency. And he said, for a little while, I did feel unfairly judged. And for a while, I felt like people would hear these things about my experience dealing with the substance use, and they would look at me as weak, like there was something else wrong with me. And he's saying that as the sibling of a stepbrother who had a substance use dependency. So this is one of those situations where perhaps nobody said or did anything, but he's feeling, and people could have, right? But he's feeling that self-stigma, right? And he's internalizing that. So sometimes it's, again, not always something that somebody else says, but it is just the way we feel because of the way we've been socialized, right? We have another individual. This is a 52-year-old woman whose daughter had a addiction to heroin. And this participant actually has reached out to me, and we've been in touch over the past, she was one of my first participants, over the past 10 years. Her daughter has been in recovery for about 4 years now. She's getting a social work degree. And anyways, it's just one of those things that's really lovely to kind of be able to keep in touch with these participants, sometimes in obviously ethical ways. But so with that context, she is talking about her daughter and saying, she just basically attacked me and said, oh, well, your daughter is a heroin addict and she stole Papa's needles, which she had stole her grandfather's needles for his insulin, which I don't even know if that's true. It could be, I'm not sure. And if that was my kid I found overdosed, I would have called the cops and had them put in jail. And just said very hurtful things. And sorry, additional context, she's talking about her sister-in-law was saying these harmful things to her about her daughter, just to clarify. And so they were kind of in this argument, and the sister, you know, as it escalated, kind of threw these things at her, and it was very impactful for her, right? One of the key markers of stigma are labels. And so when we say things like addict, we are labeling an individual, right? And that language that we use then ties the addiction to their identity and makes that kind of like a key marker of who they are. And that's one of the ways that the language we use can be deeply stigmatizing, right? And it can be things that we don't realize we're doing over time, but we just say. But anyways, this is one of the ways that a parent experienced the stigma. And moving on to talk a bit more about that, one of the most prominent ways that families have experienced stigma in extant research, but also in the research I've done, is primarily like stigma towards the parents. So parents face, I would say, an elevated burden of stigma when we think about a loved one having a substance use dependency. Parents are blamed. They're also the ones who are like the responsibility is kind of put on them to help the person enter recovery or maintain sobriety, right? And so we have this situation where a 31-year-old male was discussing his parents' role with his brother's dependency, and this stigma towards the parent was coming from one of the other siblings. And he said, his behavior, the brother, is a reflection of their upbringing of all of us, specifically him. So this stigma can come from within the family, and it can be directed towards individuals, but primarily that blame is placed on the parents, right? And then this woman, the other one, the same one I referenced earlier, she had said in one of our interviews, "You didn't have to tell me it was my fault. I already knew," right? So the blame can be placed on the parents from others, right? Inside the family or outside the family, but also oftentimes individuals will place that blame on themselves, right? So there's that self-stigma again, and bearing the responsibility for the substance use. So far I've covered some of the ways that families have talked about their experiences of substance use, or I'm sorry, their experiences of stigma related to substance use. This can look so many different ways. I have had folks talk about situations where strangers, they experience stigma from strangers, but most often when they talk about the stigma they've experienced, it feels most harmful when it comes from an individual they're close to. So if it is a family member or a close confidant or a friend. They've also expressed where in healthcare situations, folks will experience stigma. So I've done some research there too, but I'm not focusing on that necessarily today, though I've done some research in emergency departments specifically on the way that stigma is communicated there. If we want to show a few examples of different sources of stigma, if we're looking at outside the family, we have one person who is a spouse who was talking about her partner's alcohol use disorder. And she was talking about how his family and his friends would characterize her because of his dependency. And so she said, well, they always think like his wife must be a B because he doesn't ever want to be home. He'd rather be out in the street or out doing this or that versus being home. So she feels like there's always this judgment of people are blaming her, right? He's turning to maybe drugs or alcohol because she's made home life so unbearable in some way, right? So bearing that blame, but saying that it's coming from folks outside of the family. And then as I've already shown you a little bit, that stigma can also come from inside the family. And the folks that I've interviewed have primarily talked about these experiences where it's coming from a friend or someone inside the family. So we already saw where the son was, stigmatizing the parents. We saw where the mom was stigmatizing herself, right, and carrying the blame. And then we also have this example of a mother talking about how they feel that they stigmatize their own child because when they were early on in their experience of having a child with a substance use disorder, they felt they didn't fully understand it. And so they felt that they perpetuated that stigma themselves, right? And so she said, I think when we finally said to her, we get it, like, I get it, I understand this isn't something you can control. She felt very relieved by that because I think she felt really judged. And like we were, I guess, I would say, judging her on that. She was making bad choices on purpose, and it made her feel really sad, right? And we'll talk in a little bit more about how this transformation process can kind of happen over a period of time of having a loved one with a substance use disorder. Okay, so we've talked a bit about how families experience stigma. I want to move into where most of my research over the past 5 to 7 years has been focused, which is we know the stigma is happening, right? I've done the groundwork and other folks have done the groundwork for us to understand what it looks like for these family members. Now, my goal is to focus on how can we understand the way they're managing it in efforts to inform like best practices for clinicians to guide patients towards productive and healthy coping, right? So if the strategies they're using are not helpful and they're harmful, how can we guide clients, families impacted by substance use towards strategies that would be helpful, okay? So I do this work based on a theory that's called stigma management communication theory. And it is a bit of a complex theory, not that you're not all capable of understanding it, but I'm just going to explain a kind of a subset of this theory that's relevant to our discussion today. And I'm happy to share additional like readings and things on it if anyone's interested. I know you're probably all dying for something to read, right? But this is a table from one of my publications. This one's from 2023, I believe. And this theory overall asserts that the way that an individual perceives stigma towards some kind of attribute, substance use, whatever it might be, shapes the way that they will manage that substance use, how they'll respond to it. Okay. And so based on this theory, there is then a typology that shows you kind of like if they feel in these exact ways, they are more likely to use this type of strategy. So let me explain that more in detail. Essentially, if somebody accepts that the societal perception of stigma, which would be that people who have a substance use disorder are stigmatized, right? It's a moral failing. I don't think that, but you get my point. If they accept that, and then they also accept that they should be judged because of that stigma, like they agree with it, they would be more likely to use these accepting strategies. Okay. If they accept that that stigma exists publicly, but they say, hey, that doesn't apply to me, they'd be more likely to use what we would call avoiding strategies. And we can go like further on and say, if they challenge that societal stigma and say, I know that some people feel that way, but I don't think people should, like that's not valid, right? They're kind of challenging and standing up to that stigma. And then they're also challenging, it would apply to themselves, they would fall into this full challenging strategies category. But if they challenge that stigma and somehow still find a way to judge themselves or judge their loved one, they'll use these strategies, which we call explaining. I know that I've just thrown like a lot of different things at you. I'm going to show you some examples and go over these kind of with some exemplars side by side. I wanted to give you a bit of a bird's eye view before we dove into those individual things. But essentially, by being able to predict the way that people will manage stigma, my goal is to find out how we can then build a model to predict that the way that the strategies that folks employ predict relevant outcomes, right? And hopefully we can build some patterns of what strategies lead to, better well-being, right? That exemplify effective, healthy coping, that show resilience, right? All of these things that we'd like to see in individuals who are experiencing stigma. Okay, so let's go through some examples so I can illuminate this a bit more, but I just wanted to show you kind of the basis for how I've approached this work. Okay, so if a family member is using an accepting strategy when they are experiencing stigma, so somebody says something negative or judgmental about an individual in front of them. So they might say, oh, I saw somebody outside, and then they might use a term like they like a junkie, right? Like that's a label that folks will use. If somebody is using an accepting strategy, they might agree. And then because they agree, and maybe they've also internalized the stigma, they feel shameful. And they might use a strategy like passive acceptance is one of these. And so they just kind of like maybe nod along and don't say anything, right? That would be an accepting strategy, almost like resigning yourself to the stigma, okay? So some examples from my work, if we use passive silence, this is somebody said, a son of a parent with a substance use disorder said, usually, honestly, I just ignore it, stigmatizing comments. I don't think it's worth getting into fights over. So the reasoning for why people do this can also vary, right? This is a nuanced process. But this person said, it's just not worth the effort, right? And this was a common sentiment across participants really over the past several years across my studies. Another accepting strategy where people, again, accept that the stigma exists and accept that it applies to them is one called bonding with others. And this one's really important. This is where we find folks turning to support groups, right? Or turning to support from others who have similar experiences. So it's one of those situations where, you don't talk about an experience with somebody because they don't get it, right? But you wait and you talk to the individual who does get it. That's bonding with stigmatized others. So this individual says, it's like with anything, if you've never experienced cancer in your family, you don't understand what it's like. It's the same thing with opioid misuse. It's hard to get support from people who haven't experienced what you are experiencing. Okay. And then this was a younger woman. She was a daughter and a sibling. So she had 2 loved ones with substance use disorder. And she said, my best friend has a very similar situation with her own mother. So that's been incredibly healing for me. And she talked a lot about how her and her friend were able to help and support one another. And in having somebody who really got it, it's validating, right? And it helps people move through this experience in a way where they do feel supported. Okay. And then another accepting strategy is internal attribution making. So attribution making is where we just assign reasons, right? And an internal attribution making would be blaming the individual. Okay. So this family member said, I don't know if I truly believe it's a disease because I do still think it's a choice, even though I know it's not that easy to stop, right? So this would be playing into that stigma, right, of assigning it as being a choice, not something that people, or thinking that people can just stop at any point in time, right? So those are the accepting strategies. There's a lot more. I just kind of picked some examples for you, but there are like 20 something strategies overall from this whole theory. So I won't go into all of those. But if we move on to what would be like quadrant number 2, so avoiding strategies, these are where folks, again, they accept that the stigma exists in society and they might agree with it even and validate it, but they don't think they should be stigmatized, right? So like, yeah, people should be stigmatized, but not me, right? So when people have that belief that they hold those stigma attitudes, they might do something like avoid stigma situations. So they won't put themselves in a situation where they have to disclose about their loved one, or they might hide that their loved one has a substance disorder, something like that. So some examples of a family where they were at a holiday gathering with kind of extended family. She said, we were embarrassed, obviously, and we were trying to maintain his reputation. My elderly parents were alive at the time. They'd be over at Christmas dinner or Thanksgiving, and he wasn't there. He would either be on the streets, in jail, or in rehab, and my parents would say, where is he? And I would lie and say, well, he's at his girlfriend's house or in the suburbs of the city having dinner, right? Just kind of make up something to avoid putting themselves in the situation of being stigmatized. Because if they disclose what's really going on, they fear that they will be judged, okay? And then we have some other examples here of where they say we just sweep it under the rug, we don't talk about it, we avoid it because we don't want to damage our loved one's reputation, okay? Another way that folks say like the stigma exists but not me is by doing something called making a favorable social comparison, where they say, well, the stigma doesn't apply to me because our situation isn't as bad as others. It's not as severe. So hearing all of these other addiction stories that were so horrible, I'm like, this is not me. I don't belong here. There's a part of me that's like my experience wasn't that bad. And other folks will have said things like, well, my loved one, they became addicted because of they were overprescribed opioids, and they're not, like injecting heroin. So they're not as bad. They'll literally say they're not as bad as others, right? And so it's like distancing oneself from the stigma, okay? And it's important to understand the strategies that folks are using because it gives insight into the stigma attitudes that they hold, right? And we want to understand those stigma attitudes because we want to hopefully be able to shape them to change these strategies in efforts to lead to better outcomes, okay? So with explaining strategies, these are the ones where we might be challenging the public stigma on some level, but we also are still accepting that we're stigmatized to some extent, okay? And this really is just rationalizing, Okay, so one like sub-strategy of this would be trying to challenge other people's thinking, right? With reducing the offensiveness of their loved ones, like substance use, right? And this individual did it by drawing attention to who they were before the substance use. Okay. And really challenging and saying, essentially, you're reducing them to their addiction and you're not really thinking about the whole person. Okay. And then we have external attribution making, whereas the other one was blaming the individual. These explaining strategies would provide rationales for how the substance use disorder was outside of the individual's control. Okay. And there are a few examples here. This individual was placing the control outside of their own responsibility. So while still stigmatizing their son, they essentially said, this isn't my fault though. So these individuals are managing the stigma sometimes for their loved one, but also sometimes for themselves. And that's one thing that is really interesting and nuanced about looking at this family stigma process. But then other folks have gone on to talk about how different hardships might be the reason for why an individual has a substance use disorder. So this person lost their dad when they were young. This person talked about how addiction is a disease and it's not just something you can stop. So there are a lot of different rationales. These are all things we've probably heard at some point in time when folks talk about a loved one with a substance use disorder. It's not their fault. They were overprescribed medication, right? They didn't know, those types of things. And then the last one is called minimization. And it's just, again, a bit of a distancing strategy where folks will focus on the positive things about their loved one and say like, yeah, they have this substance use disorder, but they're also really wonderful in all of these ways, right? Like, again, this isn't the only thing about them. And they try to minimize that stigmatizing attribute and focus on the positive things in efforts to reduce the stigma, okay? And then the last one is the challenging strategies. And I just developed a scale for this theory. And so we're very close to, we're publishing that now, and then we're going to test this theory. And my suspicion is that where we kind of want people to be is in this category, but we haven't fully tested it, so I can't say that for sure yet. I just want to caveat, okay? But we're almost there. But anyways, these challenging strategies are the ones where folks are essentially just fighting back and saying the stigma shouldn't exist, right? And I'm not stigmatized and you can't stigmatize me, okay? So really in this advocacy kind of space. People do this through several different types of sub-strategies. One of them is a logical argument. Often this includes education. So if I hear people say stuff now, because it's still very hurtful to hear people talk like that, knowing that they're talking about someone like my sister, they've taken the approach of saying, well, just so you know, my sister died of this, and this is what you're like, this is why what you're saying is wrong, or it's hurtful, or it's incorrect, right? So they'll try to educate others to challenge the stigma. And then this person, when they were talking about their son, was talking about how really their child was raised in, honestly, just a very privileged home, and it happened to her kid, so it could happen to anybody, right? And to try to challenge the stigma. Another one is advocating. So a woman who was a nurse talked about how over time, her and her daughter got to a space where they actually gave a talk at her work for other clinicians, right? And so they were advocating. The one woman who I talked about earlier, whose daughter is in recovery, she runs a chapter of a nonprofit that helps families back in Michigan, which is where I'm from. So a lot of these folks end up in a very like forward, front-facing advocacy position, right? They almost take up the cause. And that's something that we've seen happen often. Okay, these are all the different types of strategies. I want to talk to you about how these shift and change over time, and then why all of this matters, okay? So again, how does this change over time? What I've seen in my research and also in other research is that over time, as families experience as their experience goes on of having a loved one with a substance use disorder, the way they think about it changes, right? So they might initially have strong stigma attitudes themselves towards their loved one, but because they then experience it themselves, that changes, okay? So an example here is I was prejudiced in a sense against them, people who have misused opioids, that, oh, they're losers, they need to get their shit together, just, oh God, look at these people, right? But without realizing that now nobody wants to be an addict, nobody wants to be there, right? It's a difficult thing, and I didn't realize any of that. I just thought, essentially, you've done this to yourself, right? But over time, their attitude has changed. And that's something that's backed by research, right? We call, like, oftentimes a contact intervention will be used to help reduce stigma by having folks interact with people different than them or who belong to a certain group, right? But so these stigma attitudes change over time because they have more exposure to this experience. This also means that the strategies change, because that theory says that the way that people think about stigma shapes the strategies they're using, right? So if their attitudes towards stigma are changing, the strategies they use to manage the stigma will also change, okay? So some examples here really highlight how folks might shift from those accepting and avoiding kind of quadrants to the challenging ones. And they'll even kind of acknowledge it. And I view this as really just highlighting how the experience of having a loved one with a substance use disorder is transformative in nature, okay? So at one time I would just cry inside, I'd go home, cry and get angry, but now when somebody would say something stigmatizing, but now I just say things like, well, unless you've been through it, you really can't understand. Unless you're in somebody's shoes, you really don't know. It's not the parent's fault. It's just something that you should really learn a little bit more about before you talk like that. Okay, but they're acknowledging, like, that's what they do now. That is not where they were at the beginning of their experience. Okay, there has been a shift. And then this person talks about how, they didn't start sharing or talking about their experience until 6 or 9 months down the road, right? So at the beginning, there was that perhaps accepting, isolating, avoiding, and then over time, they start to open up, okay? Okay, so I think I'm doing okay on time. So I've got some key takeaways and then we'll wrap up. Okay, so again, these are key takeaways from my research over the past 10 years that have kind of built up to where I'm at now. So again, the strategies that family members use reveal their own stigma attitudes and how they're coping with stigma. So if someone is primarily using those accepting strategies, and they're isolating and they're hiding the stigma and they're lying about it, and they are passively accepting stigma when other people talk about it, that signifies that they're internalizing that stigma, which we know has negative consequences for them, right? We went over those at the beginning of this talk. So when we analyze the way that people are managing stigma, we can gain insight on how they're perhaps even internalizing or rejecting stigma, okay? We also know throughout this process, it's very clear that managing stigma is complex, it's nuanced. Oftentimes, people will use multiple different strategies, even at a given point in time, but it's because who they're talking to perhaps, right? So maybe they'll use a certain set of strategies if they're talking to coworkers versus if it was a close family member. So that shifts and changes, and sometimes they can contradict one another. And I've already talked about this a bit, but these changes in strategies highlight the transformative nature of families' experiences as they're dealing with a loved one's substance use. That's something that's come up in every single study I've done with families to talk to them about their loved one's experience. So it shows us, though, that if we want to think about this from a practical sense, we can look at what is getting people from point A to B, right? Because we know what's happening. And if we can better understand how folks are moving through that transformative process, maybe we can try to speed it up in others, not in a way to like invalidate their experience or anything, but to help them get to a place of healthy coping, right? So that we can minimize the negative consequences on them as individuals, okay? We also know that the way that families talk about their loved one's substance use, or this is what I found, impacts their own stigma attitudes. So if in the family unit, the entire family does not talk at all about the substance use, that then implies that it's bad and it's dirty, right? And then the siblings and the kids, they won't talk about it or feel like it's proper to talk about it. So then also people aren't going to seek support. Okay, so that's another intervention point, is helping families learn how to talk about this, especially in ways that are appropriate for various ages of kids, right? Because the way you talk to a 6-year-old is different than your 13-year-old. Okay. But if they are engaging again in any of these behaviors, it indicates the internalization, and that's going to happen and ripple throughout the whole family. And as I kind of hinted at earlier, we don't currently know the outcomes of these various strategy uses. I could guess, right? If we're in that accepting strategies, right, and we're isolating and all of that, we'll have poorer outcomes. But we don't know that yet. And that's where I'm at now. So we developed that, we got some funding, we developed this scale, and my goal is to link the various strategies to outcomes so we can identify perhaps a tool or an instrument that practitioners can use so they can help guide families to effective patterns of strategy use. And I'll show you just a couple of scenarios of how we see that playing out, okay? So practitioners currently can still use these findings informally to guide their practice, but we'd like to have a formal tool in the future. So for example, if an affected family member appears to be using strategies associated with internalizing the stigma, like isolation and avoidance, they can work with that AFM to find more ways to better cope with the stigma, okay? So if we know that bonding with the stigmatized is something that can support them over time, then maybe point them towards mutual support groups, right? And if there isn't one, create one, okay? If they find that an individual is using attribution making or denial, then they might educate their client to help them better understand the situation so that they refrain from using those strategies. And then finally, and almost most importantly, is just validating the client's experience, right? The way that people use these strategies is, again, complex and nuanced, and we can't make assumptions about what is right or wrong about this process, or that there's one right way or wrong way to do it. What is important to understand is that the strategies they're using might be most effective for them in that moment in time. So again, we can't assume that isolating is always bad. Maybe isolating and avoiding is a protective measure for folks to just kind of survive in a moment, right? Like they can't face the stigma at that point in time. Maybe they need to build up some other coping strategies because then in the future they can face and challenge it. Okay, so it's important not to just assume that somebody's engaging in a maladaptive strategy, but more context needs to be gained in those types of situations. Okay. And then lastly, before I am fully done, I'll also mention another thing I'm working on right now, which is I've done this timeline study where I've interviewed 50-ish family members 2 to 3 times each, and we've built timelines of their experiences. We've mapped them out and built visual timelines of their experiences of their loved one's substance use to find what we're calling critical turning points. So that we can identify what are the gaps in information, resources, and supports at each of those intervention points, so we can develop those and deliver those. So I'm working on an mHealth intervention for that right now too. So perhaps it's at the overdose point, right? And we've identified what are the gaps in services, resources, supports, and we want to build a program to then help fill those spaces. And part of that is, of course, stigma, right? It's couched in there, but it's just very exciting. I'm excited to move that project forward. Okay, I've been talking at you for a long time, so I'm done. I feel like I have so much more I could tell you, so I'm going to stop there. But if you have questions or if you're doing work relevant to this and you want to chat, please email me, and I'm happy to talk more. Okay.
Thank you so much, Sydney. I do have a question, but before I just wanted to thank you. I really appreciated how you kind of touched on the language that we use really just ties things to people's identity, and it's really important to kind of watch the language we're using, especially in certain types of situations. So I really appreciate you kind of bringing that up as well. And for my question, actually, just to open up the question and answering period, I
Mhm.
was wondering, like, throughout your research, have you seen kind of maybe not an urban-rural divide, but are there different kinds of stigmas, or does stigma look kind of different, or maybe stigma in care, does that look a lot different in an urban community versus a rural community? And what have you noticed specifically?
Mhm. That's a really good question, and it's not something I have explicitly examined, but now I've like want to write that down because I think I should. I will say anecdotally, what my kind of knee-jerk responses based on my data is, like I said, I'm from Michigan. I've done a lot of work in the Detroit area. And then I've moved here, and most of the work I've done since I moved here, because I moved here in April 2020, okay, has been more like Zoom interviews, right, with folks across the country versus just in-person things in the area I was at. Anyways, my point in saying that is, what I've noticed is in suburbs in particular, in some of these more privileged, definitely more like wealthy white areas, the stigma is really attached to reputation. Like, and I mean, not that it isn't always attached to reputation, but it's really heightened. It's more about protecting like the family's reputation over even the individual. Does this make sense? Right? Because there's this
Yeah,
persona
yeah.
that has to be put on of being like perfect or whatever it might be. Um, so there's that. And I mean, it's hard to say, the healthcare work I observed in an emergency department in Detroit for a long time. And I did like ethnography essentially to see how stigma was perpetuated. Um, and that was interesting too. It's just, I don't know. I guess I don't want to speak to it without having data, but I do think that even maybe more so than urban versus rural is social class is, and not that those aren't associated in some ways, right? But I think that social class makes a big difference. So
Okay. Thank you. Almost like kind of touching on intersectionality at that point and just, yeah, thank you. That's a great answer. And then I see that Lindsay has their hand raised, so you can ask your question.
Thanks. I was wondering if you've done any research on how state policies lead to kind of that stigma and like how they affect each other.
yeah, that's a good question. So when I was in Michigan, we had one of those SOR, like state opioid response grants, right? So we did a lot of work actually on public policy and people's perceptions of policy. Um, I'm trying to think of what our key findings from that were. What we have found is when public health officials claim that substance use is solely genetic and that it's a disease, it actually perpetuates more stigma. And I shouldn't say more, but it perpetuates stigma because folks then see it as something that is unavoidable and not unstoppable. And so they then want to distance more. So they might, like, they don't want to procreate with somebody who has addiction in their genes. Does that make sense? So we have seen that when it comes, that's not necessarily policy related, but that is something that is related to policy and it guides policy. So that's why I'm sharing that aspect. But generally, I don't think that I have anything more than that. I'm sorry. I have been getting more involved in policy work lately, but I don't have anything to report on it. So,
And have you gone into like what type of programming might help the families and stigma and things like that?
yeah, that's what I'm working on right now. So, and we've been working with families, so we're co-designing this intervention to ensure that it's, even though I do have the lived experience, we shouldn't base everything off of my experience, right? Like this is nuanced and complex. So we're co-designing the intervention with folks that have this experience in a lot of different ways, right? And in doing that, what we're learning is folks benefit from different types of support. So some people want information, some people need actual like social support, some people need access to resources. And so the program that we're developing again is trying to hit on all of those. And so we'll have modules that'll be almost like I don't want to say choose your own adventure because I don't think anybody chooses this adventure, but essentially it's almost like people could take a quiz and it'll guide them down the path based on their needs and preferences for what they'd like to get. Is that helpful?
Yeah, can I ask you one more question? Sorry, I'm probably
Yeah,
monopolizing
sure.
your time, but have you have you noticed any type of like in the programming that's needed, any type of like regional settings? Let's say like I live in Texas and I've actually created a bunch of like a family training programs and
Oh,
things like
cool.
that for I'm a peer. So like maybe in different ways, different fields can have that programming and how to adapt it to the job.
Yeah. So do you mean for like peer workforce services or?
Yeah, so like how it would look different between like a clinician training or a family training or like
Yeah, I haven't yet just because we haven't fully developed this intervention, but it's something that I fully intend to scale and adapt, right, in any way that it can be helpful for others. So some of the work I've done, I do a lot of work with social workers, even though I'm in comm studies, and we've done a lot of peer workforce research as well. Um, and one of the things that we think that we're moving towards working on in a separate project is education around harm reduction. That's something that we found that folks in the peer recovery workforce identify as a need, but also it's related to stigma because there's this idea around, abstinence is the only, is the right type of recovery. And that then can lead to stigma towards people who use medication to assist their recovery, or who maybe like they might drink alcohol or whatever, but they don't engage in perhaps like the harder illicit drugs, but they wouldn't still be welcome in certain recovery spaces. Does that make sense?
so I have a resource for you if when you get to that point of it. Harm Reduction Works is an online group, they like support group, right? They have a parenting group for Harm Reduction Works.
Okay, awesome. I'm writing it down. Thank you so much. That's really helpful. So great, thanks.
Awesome. Thank you. And I'll leave the floor open for a few seconds. If there's any more questions, you can raise your hand or just come off mute, or you can drop that in the chat if you don't want to come off mute. But just leaving it open before we hop into those breakout rooms for our case questions.
Good day, this is Kurt. I'm up here at Utah State. Thank you for your presentation. We've talked in this ECHO network a lot about stigma and about how stigma affects all aspects of life, but having you explain the different types of stigma and the way that people manage it was really informative. It's always interesting to me, I don't know if it's a question or more just an observation, that stigma really goes along with societal norms and societal expectations. And it's always been interesting. I grew up in California, moved to Utah about 25 years ago, and definitely different expectations and social norms here in Utah than there are in California, and I imagine other places outside Utah. But it's interesting, Leo's question about rural versus urban. One of the and I'm on the ECHO team here, and one of the main tenets of ECHO is to make sure we're getting information out to those in the rural areas.
Yeah.
And so it'd be interesting to know if you ever come across anything like that with regard to the rural versus urban and how to manage stigma. Because again, expectations are going to be different in the different areas,
Yeah.
but the management techniques and that kind of stuff would be interesting just because we do have a fairly large group from rural areas and a fairly large group from urban areas in this network. So thank you. Thank you for your research. Thank you for your presentation. I appreciate it.
Yeah, no, that's a really interesting comment, and it did make me think. As I brought up the harm reduction, that is one thing we've noticed is maybe an increased stigma towards harm reduction in rural areas, and part of that could be just because access to harm reduction in those areas is I mean really low, and so again, lack of exposure and understanding could contribute to that stigma. But that is one thing that we have found, and I've been working. We haven't made a lot of progress recently, but with Mindy Vincent of Utah Harm Reduction Coalition. I don't know if anybody in here specifically studies substance use and has worked with her, but anyways, in trying to find ways to have mobile services or to kind of increase access in those spaces, and then try to reduce the stigma. But you also make a good point, Kurt. I'm working on a chapter for a book that I was asked to write that describes stigma as a wicked problem, right? And part of it, I think, comes back to this idea of stigma is cultural. It shifts and changes based on context, culture, and time. Tattoos were stigmatized way more 20, 30 years ago than they are now. That's because cultural norms, like you said, shift and change. And I think that's what makes it so it's really hard to pin down a cause or a solution to stigma, right? So.
All right. Thank you so much for your answers. And thank you again for presenting them. I really just found it I found it super insightful. And definitely gave me a lot more insights into stigma because, it can, when you said it can even be how we feel about ourselves, I mean, that's, yeah, it's
Yeah.
pretty good. And to preface the case questions before we hop into those breakout rooms, some of these questions are just going to focus on family dynamics, maybe some professional support, and then maybe around resources and community support as well. So I'm ready whenever you are, Tori. So I just want to go a bit over about what we talked about in our breakout rooms. So I forgot already who was leading one. So I'll go first since I was leading one. And I think a really great point that Sydney brought up, kind of at the very last minute when we were about to close, but she said a really great idea that we need more children's books explaining some of these situations regarding substance use disorder within the family, because sometimes some of those children books that are already out there don't really do a good job of explaining it, I guess, through the family unit or kind of through a child's lens. So just more children's books or just more accessible materials for families to understand. So I thought that was a really great point. And then I think Janelle led a room.
Yes, and so we had about the professional support and different ways to build those relationships. We had a great discussion. Some of the things that we really talked about was providing resources and also checking your own implicit biases towards the family and the situation, as well as really working on educating the individual and family is also ways to build trust.
Awesome. And then I'm sorry, I don't know who did that last room. So if you could, thank you, Kurt.
Yeah, yeah, you bet. So we just talked a lot about, our question was on how does it affect people's how does it affect early childhood? How does it affect getting them seeking out early childhood services and that? And really what it came down to is that there's just that stigma of knowing we had somebody share an experience that, I didn't want to do X, Y, and Z, or I wouldn't want to do X, Y, and Z because they might, if I got drug tested or something like that, then they're going to take my child away. Or even if it was later, if I had a history of substance use, would they take my child away? And so a lot of what we talked about is people's lack of desire to put themselves in a situation where they might be stigmatized, which could result in the child being taken away or could result in the child not being able to access the services in the same way that others would. But it was a great conversation, and some really good insights from the folks we had.
Awesome. That's really great. I like hearing all the great ideas you guys come up with in your breakout rooms. So, thank you again to Sydney for presenting on stigma. I thought that was really great and insightful. Our next session will be on March 11th at the same time, the same place, and we'll have Dr. Schmid and I think Jasmine Charles presenting on maternal perinatal substance use disorder and health. And if you would like to, please email projectscope@usu.edu if you'd want a Canvas page invite. And again, don't forget to take that survey that Tori's been dropping the link for throughout the session. It's how you can access that certificate of attendance. So yeah, that's all I got for you guys today. Thank you.